Well, good morning, everyone, and thank you for joining us for November's edition of Health Bytes with Region 3. We are so pleased to welcome this month's speaker, Dr. Tenise Hordge. Dr. Hordge is a visionary leader and maternal health advocate dedicated to transforming how families experience pregnancy, birth, and postpartum care. Holding a doctorate in healthcare administration with a focus on maternal and infant health, she leverages her academic expertise and over 18 years of corporate leadership experience to advance equity, education, and empowerment in maternal wellness. Excuse me. As a founder of Mother's Magical Milk and More Milk, Dr. Hordge champions access to lactation support and breastfeeding education for all. Her work bridges clinical knowledge and community impact, helping organizations, healthcare professionals, and parents create sustainable systems that improve breastfeeding initiation, duration, and overall maternal outcomes. Blending her analytical foundation as an industrial engineer and her strategic insight as an MBA, Dr. Hordge brings a data-driven yet deeply human approach to maternal health advocacy. Through her leadership, coaching, and speaking engagements, she inspires others to challenge inequities, prioritize family wellness, and reimagine what's possible for mothers and babies everywhere. In today's Health Bites, our speaker will give a presentation on the science of low human milk supply, going beyond supply and demand. Dr. Hordge, thank you so much for being our speaker this morning, and I'll turn everything over to you.
Margie and team, thank you so much for having me. Thank you, Bailey. I am super excited to share with y'all today. So good morning, good afternoon, good evening, wherever you might be tuning in from. I'm going to bring up my slides so that we can get started here. I am not a lecturer, so this is going to be interactive. I encourage you, when the time is right, to participate in the chat box. Bailey is going to be helping me out and letting me know when you guys pop some questions or answer some of the responses that I have in here. So again, thank you for the warm welcome. My name is Dr. Tenise Hordge. I want to spend some time with you all today to talk about going beyond supply and demand as it relates to human lactation. Too often we hear low supply and we just kind of think, well, why didn't the mother bring the baby to the breast more, or why isn't this working as planned? And so and within the next 30 or 40 minutes today, I want to offer you some background information on the complexities of human lactation and some of the areas or contributing factors in which we see that human supply or that copious onset of milk production breakdown. So this is me. We talked a little bit about this in my introduction. I'm an engineer by trade, former corporate program manager, and operations leader who transitioned into the field of public health. Like many folks, parenthood kind of changed the trajectory of my life and my perspective. And so I left my corporate role to really pursue my passion of human lactation and maternal health. So for nearly 2 decades in corporate America, I redirected my skill set towards advancing birth equity and supporting families. And so now with this doctorate of healthcare administration, as well as an international board certified lactation consultant, I'm really focusing on normalizing human milk and access to care. So let's dive into it. I spoke a little bit about what I want to accomplish during this talk today. And note this is very high level. So we're going to focus on really the lesser known contributors to low milk supply. So in the chat, I would love for you to drop in there. What's the most common reason you might have heard for low milk supply as it relates to human lactation? Let me know your thoughts. Spend about 5 or 6 seconds. High stress. Yeah, we're going to talk a little bit about cortisol today. Weight gain, poor diet, premature birth, yes. Nutrition, insufficient hydration, all these things. Medicine, okay. Introduction of formula, that's a big one. Cost, lack of time, poor latch, IGT, yes. Excellent. Okay, thank you all for that. With that being said, majority of time when I hear others talking about low supply, it relates to not enough feeds, that poor latch or poor milk transfer, and stress, right? So I think a lot of y'all hit that in the chat box as well. Before we kind of dive into it, I think it's really important that we distinguish between common versus normal. Too often we use them interchangeably and they're really not the same. And so to provide this systematic review of contributors to low milk supply, I wanted to break down the contributors by maternal and infant health, but let's talk a little bit about the differences between common and normal. So normal implies a standard, right, or an expectation, while common simply indicates prevalence or frequency. So in essence, something can be common without being considered normal. So for example, obesity in captive animals, so animals in the zoo. Obesity is common in zoo animals, household pets, right? But this is typically due to overfeeding and lack of physical activity. What's normal is in the wild, where these animals are eating according to the availability around them, and they're expending their energy hunting or foraging or doing whatever they can to maintain their healthy weight gain. So just because obesity is common in captivity doesn't mean that it's normal, right? So another example, skipping breakfast. I'm guilty of this. Skipping breakfast is very common among people with busy schedules or who might be dieting or for whatever habits they're choosing to skip breakfast. But it's normal to eat nourishing meals in the morning that's supporting energy levels, metabolism, and concentration. So skipping breakfast may be socially common, but biologically it's not ideal. Okay. So let's think of this in the breastfeeding world. Nipple pain. Nipple pain is extremely common. Many mothers experience nipple pain, cracking, bleeding in the early days. Normal breastfeeding should not hurt. It should be pain-free. Pain is that first indication that there is a problem, such as shallow latch or tethered oral ties, positioning issue, what have you. So pain is common, but it's not normal. All right. So just to set the stage there. Well, what exactly is low supply? Excellent question. Let's explore what that actually is. In the broadest terms, low supply is primary lactation failure, means the inability to produce the amount of milk necessary to meet that infant's growth needs. So we know that human milk production is super complex and there is not an exact number in ounces that one should produce. But if we were just to take a view from a clinical lens, it would look something like this. Again, this is a guide. Every diet is different. So as the day of life or that postpartum days increase, we see that milk supply increase. We would say that we are targeting between 2 and 6 weeks of life and beyond a daily average of 25 to 35 ounces of milk production to meet the demand of that infant. Okay. So if we have something that's falling below what we have represented on this chart, we could go ahead and classify that as low supply. Well, what are some of the maternal factors that contribute to low supply? Today, we're going to focus on hormone imbalances, insufficient glandular tissue or IGT, which I saw someone note in the chat box when I asked about what you hear about low supply, previous breast surgeries, which I think is really important, especially when we're looking at the population of late teen, early 20s who might not be thinking about breastfeeding and having children at that point, and what that can mean for them in 10 years or so when they are ready or when they are interested. I'll briefly talk about insulin resistance and then PCOS or polycystic ovary syndrome. All right, so let's dive into it. So while we understand the significance of estrogen, progesterone, oxytocin, and prolactin, and sometimes I rearrange these to say POPE when I'm teaching lactation educators to remember the hormones of lactation, there is still so much to explore regarding hormonal influence on human milk production. There are over 50 different hormones at play within the human body. Like it's a lot going on. So these hormones act as chemical messengers, right? So they're regulating a wide range of functions, including growth, development, metabolism, and even reproduction. So we have yet to reach a point where we fully understand each hormone's impact and its interrelation with human milk. There's a lot of work to be done. But today, my goal is to really spotlight recent studies of some of the better known hormones and how they may affect human production. And so on my slides, I've included where I'm pulling this data. And then at the end of my presentation, I have a full bibliography. Let's start with cortisol. I also saw stress in the chat box when we got started. Cortisol, sometimes referred to as the stress hormone, its effects on human milk production is really complex, right? So in November of 2024, researchers concluded that psychosocial stress impacts the relationship between prolactin and cortisol. not concerning there. That makes sense. While the relationship is complex and needs more evaluations, researchers found that the stressors associated with life changes during the postpartum period really have that effect on concentration of cortisol, specifically cortisol and prolactin in human milk. And this really goes to, I think someone put like the introduction of formula in the chat box, which makes sense because if we're super stressed out and maybe we're separated from baby or running errands and we're delayed in feeding and it's just easier to give baby the baby formula, now we start kind of a chain reaction that can lead to low milk supply. So this should not be surprising either. If you look at the rise in cortisol level, we see a decrease in oxytocin and prolactin. And oxytocin and prolactin are the two hormones responsible for milk ejection and synthesis. So this is significant. Well, the direct correlation to breast milk production is a little bit more tricky, right? So a 2021 study found that these postpartum stressors that I've listed here, a few of them on the slide, they serve as that catalyst for reduced breastfeeding rates. If we could better understand these stressors affecting breastfeeding in that postpartum stage, we may be able to increase exclusive breastfeeding rates. So the stressors that I've listed here, physical appearance, this whole bounce back culture, I mean, it really needs to go. It needs to just move on. Partner problems. In some data that I pulled in another presentation, one of the top contributors to maternal mortality and morbidity is intimate partner violence. Let's rest there. That's significant. Partner problems can be a significant stressor. Economic difficulties, especially in today's world of uncertainty as relates to public health and funding, feelings of isolation and lack of support. We no longer have this village or the village that we have viewed versus creating a new village. So coincidentally, some of these contributors, like I said earlier, correspond with the social determinants of health. Postpartum appearance, the negativity of the bounce back culture is harmful. And this overall lack of support as practitioners, we can accept that clients have many stressors within their lives, right? That may impact their breastfeeding journey. We can accept that. What we can do is we can help by acknowledging these stressors and being a safe place for communication, providing resources. There continues to be a need to better understand the role of cortisol plays in human milk production, but at the very least, we can understand that these stressors can affect breastfeeding. So what are some tips for success? What do? We should be bridge builders. So if we are to prioritize our care as lactation professionals and experts, first we want to feed the baby. Then we want to protect mom's supply and then get baby back to the breast if that's what mom's desire is. We should normalize this emotional experience by validating feelings, reducing guilt, leading from a place of empathy versus sympathy, right? Providing coping tools, flexible feeding plans, and resources for caregiver support. At the very least, we should be advocating for our clients and empowering their decision making to manage these stressors. So while we can't necessarily prevent these outside stressors from occurring, we can help support in several different ways that I've mentioned here as being a bridge builder. And if we can alleviate some of this stress, then we will see a decrease in how cortisol interacts or affects that human milk production. Okay, let's move on to another hormone, insulin. Insulin produced in the pancreas has a primary role in the body to regulate blood glucose levels. It takes glucose from blood into cells where it can then be used for energy or stored for use later. In women with insulin resistance and or higher BMIs, this process can be interfered with, it can be executed poorly, and this all can lead to a delay in lactogenesis or early breastfeeding cessation or shorter breastfeeding duration rates. Much of what we know about human lactation has been extracted from the bovine lactation from cows. In addition to nutrition, there is a correlation between metabolical factors, more specifically hormone regulation, that determines milk output volumes. So in humans, metabolic syndrome is a cluster of conditions that encompass that insulin resistance. So it can increase the risk of heart disease, stroke, and type 2 diabetes. Insulin resistance is one of the key features of metabolic syndrome, but it can also exist independently, so not necessarily related. It has been well established that these conditions can impact human lactation volumes. So what does that look like? Insulin resistance plays a significant role in contributing to low milk supply by disrupting the mammary gland development and secretory processes. Insulin resistance, and this can be leading to weight gain. Insulin resistance interferes with hormonal signaling or the notification process necessary for the growth and differentiation of mammary tissue. We can see this in puberty and, for disrupting that also with medication or the lack of medication can be significant later in human milk production as well. So, especially in these preconception and prenatal periods, we have to be making sure that we are having conversations with healthcare providers and seeking out the best treatment so that our bodies are functioning the way that they should. Furthermore, insulin resistance can lead to decreased prolactin, and we know that prolactin is responsible for human milk synthesis. And so, in response to breastfeeding stimulation, that can directly diminish milk production. So, even though mom is getting the stimulation on her nipple at the breast, lower levels of prolactin are not able to effectively do milk synthesis. And I see a lot of this in my practice as I focus on low milk supply. While the visual signs may be there, a good history, blood work, all these things are needed to determine if insulin resistance is present, and of course, the most appropriate next steps, which includes that continuity of care with healthcare providers. One mitigation option when insulin resistance is identified prenatally could be a comprehensive pumping plan, could be added to direct breastfeeding to encourage maximum milk production. So there are some options that we can do. We'll talk a little bit more about tips for success for insulin. I came of age in the 80s and 90s where the after school specials, right? The more you know with the star, that tagline, education is a vital role to improve outcomes. In this case, preconception and prenatal education can really help to promote positive breastfeeding outcomes. We want to focus on diet and exercise, selecting galactagogues. Researching suggested magnesium may be beneficial. However, more research is still needed. And of course, our clients are not one size fit all, right? So this is where it's very important to have that individualized care. All right, so the human breast is very complex. It's a complex organ. Male mammals typically have mammary glands, but they don't fully develop or function like those in females. So we see insufficient glandular tissue here. So before we dive into that, let's talk a little bit about normal breast development. Normal breast anatomy undergoes growth, evolution, and regression over time. The function of the breast changes dramatically between pregnancy and lactation, so much so that some scientists suggest that breasts are not fully developed until pregnancy. Case in point, we have colostrum production in early pregnancy and even the darkening of the areola during pregnancy and early postpartum. I would also like to note that breast sagginess is not a result of breastfeeding, but rather pregnancy, those Cooper ligaments, because breastfeeding gets a bad rap when it relates to breast sagginess. So insufficient glandular tissue, breast hypoplasia, is inadequate breast tissue development. It is when the woman's breast doesn't develop enough milk producing tissue to fully support breastfeeding. Doesn't mean that breastfeeding is not going to be possible, but it's that fully support. This can lead to low milk supply and breastfeeding challenges. While often related to how breasts develop during puberty, IGT can also be influenced by hormonal imbalances, health issues, and even genetics. A 1985 case study followed three women with IGT breastfeeding journey, followed their breastfeeding journey, and found a family history of low milk supply, providing the basis that further study linking genetics. So very interesting data. While IGT is relatively uncommon, most women are not aware that they have this condition. So there could be more of our population that are affected by IGT, but just don't know it. Potentially, we can have more. It doesn't mean that breast milk production is impossible. Again, it can look different in terms of ranging from producing some milk to producing a full supply. And so for women with breast hypoplasia who can produce some milk, targeted lactation support may help with that milk expression, help to maximize milk expression. When lactation is limited, supplementing feeding methods are required. And we have to have these conversations. This is those counseling skills, those communication skills, preferably prenatally or in that preconception period, but that doesn't always happen. So on the horizon, there is some hormonal therapy to promote, there is some research for hormonal therapy that will promote breast tissue development. So that is actively underway, but at this time, it's unclear if breast milk production will specifically be included in these initial trials. So remember, breast augmentation and reconstructive surgeries are our physical clues to IGT, especially if it's only on one breast. And we need to be able to elicit this information from our clients. And we have to be careful how we do that. Oftentimes, the partner might not know that one of these surgeries have occurred. And so we have to be able to elicit this information in a way that we are honoring our clients' privacy and their wishes. All right, so what are some tips for success? Well, breastfeeding can look so many different ways. We are conditioned to believe that it only looks one way, and that's just not true. We have access to human donor milk and nursing aids, and et cetera. So we have to educate ourselves and our clients by becoming adept in alternate feeding methods. And we also have to develop better understanding of these hormonal imbalances, especially in puberty, as well as endocrine disruptors and how they can affect breastfeeding later on. So again, this is an individualized approach. We want to address comorbidities, and we want to provide that emotional support, and then having whatever type of feeding plan that may include pumping and or donor milk and or nursing aids for our specific families. Okay, so what about PCOS? So polycystic ovarian syndrome was first described in 1935, and it was a collection of symptoms that included amenorrhea, hirsutism, obesity, polycystic appearance in the ovaries. Further understanding has revealed more endocrine and hormonal influences that have led to further problems, such as we talked about earlier, insulin resistance, hypertension, elevated lipids, infertility, recurrent miscarriages, and then insufficient breast development. So it is one of the most, common female endocrine disorders, estimated to affect 10 to 15% of women. But again, we don't necessarily have women may have PCOS and not know it unless, because they could be asymptomatic. Researchers have now found a correlation between PCOS and insufficient milk supply. According to a February 2025 publication in the United States, polycystic ovarian syndrome affects an estimated of 5 to 6 million women. This condition impacts roughly 6 to 13% of women, according to the World Health Organization. So PCOS is the most common hormonal disorder among women in the reproductive age and also the leading cause of infertility. So what do we do about that? What do we know more about that? So what we know is how PCOS impacts milk production, specifically by disrupting the prolactin receptors. Prolactin, again, is for milk synthesis. So it interrupts that receptor for function of milk production. We see elevated androgens that may inhibit prolactin action or too much of that male hormone, potentially affecting oxytocin as well. And that's the release or that milk ejection. So being associated with metabolical factors like obesity can also hinder human lactation. So due to these hormonal and structural factors, women with PCOS may experience difficulty with milk production or that delayed onset of lactogenesis or lactation. It is important to note that not all women with PCOS will have breastfeeding difficulties. I see a wide range in my practice. Some may be successful and breastfeed without any issues. Some women have PCOS and are asymptomatic. So it's not necessarily, quote unquote, a sentence for women who desire to lactate, but we should be aware of the underlying causes, the contributors, and of course, have a great plan, individualized plan set up. So again, tips for success. Same as I stated before, breastfeeding can look so differently. Early communication is important, education, teaching the art of hand expression, pumping routines, using nursing aids, and access to donor milk are key tools. Again, educating ourselves and our clients. And then we have so much work to do in developing a better understanding of these hormonal imbalances in puberty, as well as endocrine disruptors, and how they play a role in PCOS. Kind of along the lines, moving right along into birth control. Postpartum contraceptive use can help prevent short interval pregnancies, which have been associated with, I would say, less than desirable neonatal and maternal health outcomes. Many contraceptive methods are safe for postpartum use. However, as with any pharmaceutical drug, I mean, it's not a perfect science. We focus to highlight the safety of consuming the drug versus the adverse reaction possible to mother and baby, and then into human milk supply. Little is known about the effects on supply because we don't necessarily have people volunteering themselves and their babies for these types of studies. In terms of hormonal birth control, as early as 1984, researchers published studies on the effect of estrogen on breast milk volume. Estrogen is not recommended for breastfeeding moms, especially in the early days, as it can have a negative effect on supply. And that's why we see that because of these early 80s studies, that's why we see this in practice today. There are different types of contraception, right? So we have birth control pills, we have vaginal rings, we have skin patches, and the contraceptive shot, the Depo-Provera, all utilize hormones to prevent pregnancy. Well, families are typically counseled on the safety of taking contraceptives, but not necessarily that impact on supply. So closely monitoring supply is recommended. However, if mom's supply has already regulated, milk production increase methods become very much limited. And a quick note regarding the LAM or lactational amenorrhea method, while effective, it's imperative to understand its limitations. So specifically when working with a family who was already experiencing low supply and when other methods might be necessary. I stumbled across this PBS timeline of birth control, and it outlines like Greek philosopher Aristotle using natural chemicals such as cedar oil and frankincense as spermicides. I included this QR code, and this is also on your handouts for you to go and review because it's just jam-packed of information. It's very cool. The US has had a very complicated relationship with contraception. I think over the last 50 years, we have really started to understand the effects of contraceptives. Despite harmful ingredients such as carcinogens, we now know that endocrine disruptors associated with hormonal contraceptives specifically can have a impact on not only the endocrine system, maternal health, and subsequently on our topic today, low milk supply. In 1977, there's a study. It was with 136 lactating women. And so there was a control, 42 individuals, and then 94 that received oral contraceptives. So the combination pill of estrogen and progesterone there was a combination pill of estrogen and a low dose progesterone were used. And the change in quantity of milk were assessed by test feeding followed by hand expression or manual expression. So there's a significant reduction in milk yield with this combo pill, but not so much with low dose progesterone. So this is, again, what we see today is, especially when talking about the pill, often recommended progesterone when moms are breastfeeding because of the impact on low milk supply. Not a surprise here. Remember, the hormones of pregnancy are not the same as hormones of lactation. Estrogen and progesterone low dose pills have been seen to drastically reduce human milk supply. Tips for success. Again here, what do we do when we want to, or how should we help support families? Again, early education, specifically in the teenage and the early 20 years, before that preconception, before we are in that family planning, so we can educate as much as possible. Coaching on the LAM method and cycle tracking, clinical support, emotional support, and then again, that individualized care. Well, what about supplementing and poor breastfeeding management? The perceived low supply or topping baby off is a real issue as well. Unwarranted formula supplementation can lead to low milk supply and mom not pumping because she's not getting that stimulation from baby. Feeding on a schedule can also contribute to low milk supply versus feeding baby on demand. Sleep training, interrupting that nighttime feeding when mom's prolactin levels are the highest, are all contribute to poor breastfeeding management. So some tips again, education, resources, encouragement, and then having a clinical feeding plan. Let's pause here. So let's use the chat box here. Myth or fact? Breasts that feel soft or empty don't have enough milk. Great job. Myth. Breast softness or lack of fullness by itself does not indicate low supply, especially if baby is fed often and on demand. Soft breast can indicate milk production has regulated. Remember, milk is still being made continuously, and we don't want milk sitting, and being stored like a fridge. So great job there. What about breast size? Myth or fact? Small breasts can't make enough milk. Yeah, I love myth. Yes. Excellent. Breast size is about fat, not milk making tissue. Even small breasts can make plenty of milk. All right. So, if the baby nurses often, there isn't enough milk. We heard these clingy babies. Absolute myth. Yes. Again, by itself, this is not an indication of low milk supply. A good history, a snapshot of feeding is necessary. Frequent nursing is normal and is expected. Helps build supply. Babies nurse for a variety of reasons, including hunger, comfort. They need us. We're carry mammals. We're not nesting mammals, although we try to be. Our baby needs to be close to us. Very good. Okay, so I did want to check my time, make sure we spoke a little bit in regards to infant contributors. So after a baby is born, both infant and maternal behaviors or conditions can affect feeding. And infant factors such as cleft palate, ineffective or weak suck, ankylossia, or other known as lip tie or tongue tie, and preterm birth can prevent effective milk removal, which can lead to low milk supply. So the exact cause of ankylossia is frequently debated. Oral modal dysfunction, such as tongue tie or other tethered oral ties, can significantly contribute to a reduced low milk supply. While common, this condition characterized by an abnormal short or tight lingual frenulum restricting that lateral or wave-like tongue movement, as well as elevation, is not indicative of normal function, right? And so the difference between common and normal, and can lead to pain and discontinuation of breastfeeding, even delayed infant growth if baby is not being supplemented otherwise. In addition to tongue tie, abnormal frenula, such as the labial or buccal frenulum, can cause lip tie, cheek, and cheek ties, respectively. Helpful tips, that number one thing, feed the baby, whether that is creative positioning and or supplementing. Then we want to work on protecting supply. This is typically a pumping plan for a mom, and then oral rehabilitation. And this is a multi-provider journey, so that continuity of care. Moving on in infant-related contributors to low milk supply, hypotonia or low muscle tone. Infants with low muscle tone, they have difficulty creating that vacuum seal on the breast and extracting that milk out. So infants with trisomy 21, or more commonly known as Down syndrome, can be characterized by low muscle tone and sometimes congenital heart disease. Breastfeeding is still an option, yet it can look differently. Again, additional resources, positioning, and of course, supplementation may be necessary. In cases of infant low muscle tone, the mother will need to add pumping to her daily practice to maintain her supply. Again, 1, feed the baby, 2, protect the supply, and then if it's mom's desire to get baby back at the breast. So I'm not going to play this video because I'm always weary about bandwidth, but this is the shot that I wanted to show, right? In continuation of that oral modal function on infants, we know that low muscle tone can affect milk extraction. You can see here, this is an infant with normal muscle tone and the ability to have that vacuum seal. There's no gaps here. We see mom's nipple all the way in baby's soft palate. This is hard to accomplish in infants with low muscle tone. You can see the video here on this QR code also on your handouts. All right, so helpful tips. Well, what do we do? First, we're going to feed baby. We're going to consider a Haberman bottle and also additional supplementation. Working with a skilled and experienced lactation consultant who has had experience with low muscle tone. Patience. This might look like frequent feeds, having a pumping plan or an alternative feeding methods, and being mindful of fatigue of both mother and the baby. Okay. Checking my time here. Suck, swallow, breathe. So this last infant contributor that I wanted to share with you today is this coordination. This suck, swallow, breathe coordination is essential for safe feeding from breast to bottle, regardless of how baby is feeding. To prevent choking, infants must find a rhythm in sucking, swallowing, and latching. Most of this happens involuntarily, but the ability to coordinate suck, swallow, breathe is refined after birth. Signs of difficulty include gulping, choking, furrowed brows when the infant is feeding. The main sign indicating a problem with the suck, swallow, breathe mechanism can look like uncoordinated or insufficient sucking, maybe 10 sucks before we actually swallow. It could mean frequent popping off and taking really deep breaths, abnormal reflex activities, or even underlying neurodevelopment concerns. We see this a lot with our preterm babies. So a lot of support is needed. Again, nothing different from this slide. First, feed the baby. That may be feeding differently, different feeding methods than at the breast. Working with a skilled IBCLC and healthcare providers. So collaboration, that continuity of care, patients, pumping schedule for mom, resources and collaboration. Again, being mindful of fatigue in both mother and baby. So summarizing strategies for success, capture a good history, right? We want to understand underlying issues, lifestyle, previous experience. We want to know if there's regular cycles prior to pregnancy. There is difficulty getting pregnant. If the pregnancy was healthy, if there's a history of breast surgery or biopsies, if there was early or previous breastfeeding experience. So through collecting a good history, we can learn what is not being said and kind of flag items that give us pause and or change our course of action. Early intervention is best, even in the preconception or prenatal period. We want to get to root cause. So I spent my early career in manufacturing. We never just focused on the contributing causes. You want to drill down to that root cause. We want to make sure that we're not just treating symptoms. Lastly, it is very, very important to have a good resource list, but ultimately collaborative team. This is not something supporting a family with low supply should never be something that is done in a vacuum. It's all about collaborative care. So in summary, there are several maternal factors that influence human milk production and volume output. I only briefly, very briefly shared a few today. Why we have established some correlation, the exact relationship of many of these complexities I shared today are poorly understood, to be frank. So what can we do? Well, I'm glad that you asked. The first thing we should be doing is having as good practitioners is establishing a relationship, gathering a good history, planning for the ordinary and buffering for the out of ordinary. I've compiled a list of resources that I wanted to share with you and your clients, so you'll have access to that here. So I think we have time for one case study here, and we're going to meet baby Leo and his mother Marisol. So we're going to use the chat box and kind of talk about what might be going on here. Marisol is 33 years old. Baby Leo is 2 weeks old. Leo was delivered via emergency C-section after prolonged stage 2 labor, so lots of pushing. He is exclusively breastfeeding. Mom notes that every time he latches, it hurts so bad. I want to cry. I keep trying different positions, but nothing helps. My nipples are cracked and I dread every feed. What information might we need to know? What might we want to ask mom? Let's put it in the chat box here. What information do we need to know? We need to get some more information here. Yeah, what feeding positions have we tried? Maybe we can, we're in a situation where we can observe feeding. Is the baby gaining weight? Excellent. We want to know what output looks like. What do wet and dirty diapers look like? We want to understand if there's an oral assessment has been done. How is baby latching? Yes, any breast surgeries. Talk about mom's diet. Good stuff. So let's say that we have, I'm trying to move forward here, some more information, background notes. Oops. All right, so Leo recently regained his birth weight, but he's very slow to feed, 40 to 60 minutes, very long time at the breast. Marisol reports using a nipple shield after nursing. She thought that might help. She states that Leo clicks during feeds and easily slips off the breast. Leo is fussy after feeds and often pulls off crying. No oral assessment has been done. All right, so with this bit of information, what might we have ascertained? Yeah, I definitely want to know about mom's support system, poor latch, maybe some tethered oral ties. Definitely needs an oral assessment. Infant motor skills, excellent. You guys are hitting all the right things. So we want to, we talked about some of the clinical signs that we looked for. We want to understand Leo's feeding patterns. Next steps, definitely do that oral assessment. We want to note about milk production. Is she doing anything if Leo is not emptying her breast, extracting all the milk? Do we have a pumping regimen? All of these things. Excellent. Muscle tone, great job. Perfect. I think we do have time. Bailey, Margie, help me if we have time for one more.
Yep, I think you're good, Dr. Hordge.
Perfect. Let's go on to one more case study. Let's meet Jasmine and Amari. Jasmine is 30, Amari is 10 days old, full-term vaginal birth, minimal complications, exclusively breastfed. Amari is always on the breast, but he's fussy and sleeps a lot. I've been pumping after feeds, but barely getting anything out. A little bit of background information. Amari has lost 9% of his birth weight by day 5 and has only gained 2 ounces since then. Latch appears adequate per the hospital discharge notes. Jasmine mentions she's never felt that full, even when her milk came in. Her breasts are a tubular in shape and widely spaced. She reports high levels of stress due to returning to work remotely in 2 weeks and a lack of sleep. So what are some clinical indicators that we have already assessed from the background information between Amari and Jasmine? Mom's stressed out. Yep. What else? Yeah, low milk indicators, exactly. Stress levels, IGT, high cortisone levels. Mom's going back to work in 2 weeks. What about the tubular in shape, widely spaced breast? Never felt full. Baby's on the breast, not seeming satisfied, slow weight gain. Lack of glandular tissue, exactly. So what might we ask mom? What are some questions that we might elicit from her? Think of that history, think of the background. History of breast surgeries, yep, past surgeries. I also want to know about regular menstrual cycles. History of contraceptive. I want to understand how her breasts change, if at all, during pregnancy. Yep, history of diabetes, all these things. Excellent. So some questions that we might move forward with asking Jasmine, about what her experience is, what her history, and then based off of that, we should have a game plan of interventions that we should do for her. So the takeaway in these very brief case studies is we have to have that multifactorial lens, right? We need to understand history. We need to understand what feeding looks like now. And we also have to be forward-looking in creating a plan. We should be combining our clinical knowledge with a strategic approach. We should always take into consideration mom's mental state and what our plan can do to where she is on that level. So this is asking about support systems. Somebody put that in the chat. What type of resources and support does mom have at home? How can we assess her cortisol or her stress level and provide resources? Maybe that looks like a doula. And we should be leveraging that team-based support for best outcomes. So I do have my bibliography here that will you'll have access to, and I wanted to make sure we had a few minutes for questions before I turn it back over to Bailey and Mark. Thank you so much.
Yeah, thank you, Dr. Hordge. It was really interesting. I wish I would have known this when I was having my children. So we do have a couple of questions in the Q&A. The first one is, can you talk about how to manage low supply when formula or feeding are on a schedule? I think that should say that's medically necessary.
Yep. So mom needs to have a comprehensive pumping plan. So typically when feeding is on a schedule that is medically necessary, we're talking about critically ill or preterm infants, right? And so we need to make sure that they're being fed because that's the number one thing is feed baby. So we have to be careful that we are counseling mom in a way we're listening more than we're talking so that we're hearing what's not being said. And then we're coaching her on making sure that we're maintaining that milk supply through a comprehensive pumping plan. We want to evaluate that she knows how to use her pump. We want to evaluate that we have the right pump flanges and schedule for pumping. We also want to talk about breast hygiene as relates to exclusive or primarily pumping, as well as how to take care of our pump. So we want to work in collaboration with the healthcare providers that have assessed baby for this feeding plan that needs to be on schedule. And then we also want to, let mom know this is temporary. It's not always going to look like this. We need to get baby healthy or over this hump or whatever it might be. And then we can talk about what that looks like what that looks like moving forward.
Thanks. That's really great to know. So here's another question, which is really an excellent one. Do you have any tips for helping build a milk supply for premature birth at 30 weeks C-section where a baby is in the NICU for a period of time with a feeding tube?
Yes. So, I mean, individualized care. I want to understand a little bit more history about mom and if there are any contributing factors to, baby coming early, like if it was preeclampsia, whatever it might be. So we want to understand that. But generally speaking, we want to make sure that we have a really great pumping plan for mom. If mom is able to spend time in the NICU doing kangaroo care, smelling the top of infant's head, having some biological response that's happening there, but working with mom specifically on a very robust pumping plan, as well as visiting baby if that's possible.
Great. Thank you so much. Another question. Curious about different cultural traditions about breastfeeding, feeding colostrum, only eating certain foods while breastfeeding, etc.
I love it's so fascinating to me. Being African American here in the US, and the US is very much a melting pot. And so we don't necessarily have all these traditions that you might see in Latin America or in Asia, where the mom is really catered to. For example, in Asia, for the first 40 days after giving birth, is only consuming broth or warm foods. And she has everybody there helping her along. She's not really getting up and is having this moment of healing and breastfeeding and bonding. Similar cultural aspects in Latin America. And so I think that these other traditions are deeply fascinating. And I wish we could get back to that a little bit more worldwide so that we can better support this very intimate and very crucial time shortly after birth. And it direct correlation or direct not correlation, but against this bounce back culture, right? Where we're rushing moms back to work or fitting in your jeans or separation from mother and baby. So I value that. I think it's fascinating. I wish we had more of these cultural responses in the early postpartum stage.
Well, there's a lot to learn from other people. I can guarantee that. I do have a question just for myself. What about donor milk? I wonder sometimes, I know it goes through a lot of screening, et cetera, but I mean, how can you guarantee like what the person's eating is going to, satisfy the baby, like it's not going to interact with the baby or, that kind of thing, just donor milk in general. I think it's a wonderful concept, but just kind of wonder your thoughts on it.
Great question. So donor milk is it's a great alternative. So typically, I think there's 25 milk banks in North America, so including the US and Canada, and they are prioritized for critically ill infants. So NICU babies, babies that are really struggling, which is a fantastic resource. Those mothers that donate either experience the loss or just have an oversupply. And so those mothers are screened for certain diseases, even a tattoo. So if they've had a tattoo in the last 6 months, they're not eligible to give milk. But what we should understand is that human milk is produced in our blood and not necessarily mom's stomach. So yes, there are certain proteins that can transfer into mother's blood supply. But generally speaking, the benefits outweigh the risk as it relates to formula, specifically and especially powdered formula, which can't be sterile, right? Here in the US, it's very common to see a family walking around outside with a bottle of water and formula and mixing it on the go. Well, that really doesn't help us. Our water supply is not the issue. It's the powdered formula that can't be sterile. And so we're heating that water so that we can sterilize the powdered formula or get that as safe as possible. So if we look at the risks and the benefits, human milk is a far better choice if available than formula. If we look at a pyramid of supplements that we're giving our infants. So I hope that helps, Margie.
Oh, it does. It's a great. Well, thank you so much. I really appreciate your knowledge and your insight and you just taking your time to be a part of our Health Bites presentation. So I really enjoyed it. I think so many of the comments that we're seeing in the chat validate that as well. It was just really very interesting. And I just loved hearing what you had to say. So I'd like to thank you again for joining us and sharing your expertise. And we look forward to seeing all of you that attended today at next month's Health Bites with Region 3.
Thanks for watching. This video was produced by the network of the National Library of Medicine. Select the circular channel icon to subscribe to our channel or select a video thumbnail to watch another video from the channel.